Dear friends, dear colleagues, it's my great honor to join this 36th International Workshop on Therapeutic Endoscopy. I'm Pinghong Zhou from Shanghai Zhongshan Hospital. Today, I would like to talk about some new understanding of concept of endoscopic microdiscectomy. There is no COI. With the development of the endoscopy, we can now find many superficial tumors and some submucosal tumors on endoscopy. Based on the recent data, GI tumors now is top threat to the health of the people. So with endoscopy, we can now find many GI tumors. Endoscopy therapy can have equal effect to the surgery, but it is even more minimally invasive. There is no scar on the skin and the trauma is small. The patient can have a quick recovery. Minimal invasive endoscopy now is the only way to achieve early diagnosis and the treatment of the GI tumors. GI lumen is very narrow and the wall is very thin. The esophagus have some surrounding organs such as heart, aorta, and trachea. So for endoscope procedure, it is very difficult and it is very risky. So minimal invasive endoscopy of the GI tract is a no man's land in urgent need of breakthrough. From 1960s, doctors can use the snare to remove the pedunculated polyps, and this is a pyelopectomy. For small superficial tumors, such as this lesion is adenoma in the descending duodenum. We can inject saline into the submucous layer, and then with the snare to catch the whole lesion and dissect it. And this is the EMR technique. For small lesions, we can use the snare to remove the whole lesion. Let's look at this lesion. The lesion is located at the descending duodenum. The lesion was about 3/4. So we always performed PCM EMR, endoscopic piecemeal mucosal resection, to remove the whole lesion. For piecemeal EMR, we can remove such lesions 5 centimeters, 10 centimeters, 15 centimeters, but there is always some residual lesion on the wound, and it is very difficult to access, to evaluate the pathology of this lesion. So from 1990s in Japan, a new technique named ESD was performed just in order to remove the whole lesion in one piece and provide the precise histology. In July 2006, we performed the ESD in the esophagus, stomach, and the colorectum at the same time. The locus rate was decreased from 9.8% to 1%. In 2006, we held the first Sino-Japan ESD submittal for review and published the first ES monograph in 2006. So the ESD technique vigorously promoted the early diagnosis of treatment of the early GI cancer in China. For mucosal lesions, we can perform EMR, EPMR, and ESD to remove the whole lesion. How about the submucosal tumors? In the past, submucosal tumors from the muscle layer, I think it is a contraindication for the endoscopic resection. With the experience of the ESD, we can now perform the ESE endoscopic submucosal excavation to remove the whole lesion. First, remove the mucosa, then allow the capture of the tumor. Such deep tumors can be successfully removed. During the ESE, sometimes we can find the lesion was close to the serosal layer, and sometimes the lesion was in the extraluminal growth. So for this situation, the perforation during the endoscopic resection is inevitable. So we performed a new technique named endoscopic full-thickness resection to remove the whole lesion. After full-thickness resection, there are always a defect of perforation in the GI wall. So the basic suture technique is a clip. We can use the clip to close the small defect from two ends to the middle. For large defects in China, we always use pulse steering suture to close such huge defect. We used several clips to fix the end loop to the edge of the defect. Last, we can use a hook to ligate the end loop so that such big defect can be successfully closed. This is a huge stromal gist of the rectum. The lesion was about 6 times 4 centimeters. The lesion was found to operate the prostate with full-thickness resection and the string suture technique. Such big lesions can be removed on a bronchoscopy. In the Western countries, overstitch is the main suture devices to close the huge defect of perforation during the endoscopic resection. So now for ESE and the full-thickness resection, it is not recommended as a standard operation method by AST for endoscopic diagnosis and treatment of submucosal tumors of digestive tract. Tunnel technique, I think, we can use the submucosal space to act as a working space to perform some endoscopic procedures. POM for achalasia is a milestone of the tunnel technique. I first know this technology in the Hong Kong's conference in 2010. So after that, we began perform such procedures in Shanghai. Now we can use POM technique with the push and pull technique to perform more than 96% of the such POM achalasia patients. Now we have account for 1/2 of the world's total operations. And the innovative surgery methods such as push and pull technique has become gold standard for the treatment for achalasia. Third technique, submucosal ternary endoscopic resection, was performed with the submucosal tumor to remove the tumors from the muscle layer. That was first performed in our hospital. This is a series of the endoscopic minimal cell resection. For mucosal lesions, we can use the EMR, EPMR, and the ES technique. And for some mucosal tumors, we can use ESE, full-thickness resection, and STIR. Even for some functional GI disease, such as achalasia and GERD, we can perform POM and some other techniques to manage such lesions. Based on the past experience, we now have some new understanding of the concept of the endoscopic microdiscectomy. First, I think the elements of the endoscopic procedure is still, it should be efficient and fast and safer and simple. For different lesions located in different places, we can use different techniques to remove the whole lesion within a very short time. This lesion was originated from a muscle area about 1.5 centimeters. We can use the sneer to directly remove the whole lesion from the muscle layer, and the whole procedure time was only 2 minutes. So even for this lesion in the duodenum, the lesion actually was originated from the muscle layer. So with the sneer, we can remove the whole lesion with a full thickness resection. After the full thickness resection, we check the specimen. We can find the lesion was close to the serosa layer. So sneer is an old instrument widely used in endoscopic resection. So we have invented a new all-in-one sneer to perform the ESD technique. With the tip of this sneer, we can mark the lesion, we can cut the mucosa, and we can inject saline into the submucosal layer with this sneer. And we can use the sneer to cut the submucosal tumor to stop the bleedings during the ESD procedure. Even this sneer has an APC function. So all-in-one sneer was used to finish the whole ESD procedure. There was no need to exchange the instrument during the whole procedure. The second concept is, as we know, for the endoscopic resection, it can preserve the organ function. So in the future, I think endoscopic resection is becoming another surgical modality. Now in Shanghai, for gallbladder stone, we can now perform the endoscopic transgastric cholecystectomy. And this is a resurgence of the nodes based on the full thickness resection and the successful closure of the perforation. This is a pilot in gallbladder. In China, we performed endoscopic transgastric polypectomy for the gallbladder polyps. We always used the gastric access to put the scope from the stomach to the abdominal cavity and make a small hole in the gallbladder and put the scope into the gallbladder lumen. Cholecystectomy is a standard treatment for the gallbladder stone. With the nodes, now we can put the scope into the abdominal cavity and dissect the gallbladder from the gallbladder bed to the gallbladder triangle. On the endoscopy, such gallbladder duct can be cut and ligated with the end loop, and the whole gallbladder can be removed with sneer from the patient's mouth. Look, now we inject the saline into the gallbladder bed and dissect the whole gallbladder till to the triangle. At last, we can use the sneer to remove the whole gallbladder. And when we cut the gallbladder, we can find the gallbladder was full of the stone. For extra pancreatitis in China, a new technique named ERET was performed. So we use the balloon to remove the appendiculi from the appendical lumen, so that the appendix can be kept. But for some tumors located at the orifice of the appendix and some adenoma involving the appendical lumen. So, and I think the appendectomy was performed with the full thickness resection technique. So we first cut the whole layer of the cecal wall along the orifice of the appendix, then dissected the appendix from the appendial mesenteric. The third new concept of the endoscopic microdiscectomy is, in the past, we always think the endoscopic resection is minimally invasive for patients, but recently we realized it should be user-friendly for the endoscopists. I once performed gastric ESD for one young lady. So the lesion was very, very big, about 15 times 4 centimeters, and the operation time was more than 7 hours. With this patient's stomach was successfully preserved. After 7 hours procedure, it means the tumor for me is very, very big. This is another lesion in the esophagus. So the esophageal lumen was full of the lesion. With 1 hour, the lesion was successfully dissected, but it is very, very difficult to remove such lesion from the patient's mouth. So I spent 7 hours to cut the tumors into 4 pieces so that the lesion was successfully removed from the patient's mouth. After 8 hours procedure, you can see this is my left hand. So it means the tumor for me is also very, very hard. So in the future, we should invent some new accessories and to shorten the procedure time. The first concept is, with the development of the technology, the indications of the endoscopic resection is expanding, such as age and the disease. So now we can perform the longitudinal ESD for the early aging cancer. You can remove the facial tumor with the endoscopy. Endoscopic resection is widely used in adult patients. Now we performed the POM for some young children. So this child was 7 years old, but the body weight with POM procedure, the patient had a good recovery. So now we can, in China, we performed POM even for some young patients. Recently, we performed gastric POM for the congenital pyloric hypertrophic stenosis. So this patient was very, very young, always within the 6 months, and vomiting with no bile. So with POM procedure in the interim, now we can build a short tunnel in the interim and cut the second muscle in the pylorus, and at last we can close the entrance to the tunnel. 3 years ago, I finished the first case of the GPOM for such young patients in Shanghai. And now, this patient, we can see this patient was only 23 days old, and the body weight was only 3.2 kilograms. With 1/2 hour, the GPOM was successfully performed so that the patient will not have another surgery. Now we even can use the esophageal tunnel to remove the extra luminal lesions. In 2016, the first case of the actual GI tumor resected by the transesophageal endoscopic mediastinal tumortectomy was reported. It can expand the application of the tunnel technique. In 2010, in the Gut Journal, we reported another case, transesophageal endoscopic removal of the benign mediastinal tumor. It means this is a new field for the endoscopy and promote the endoscopy from the intracavity to the actual cavity. The last new concept of the endoscopic procedure, I think, innovation in the endoscopic instruments will make the endoscopic procedure thrive. So cooperation between the hospitals, high schools, and the companies is very, very important. We invented a double-arm metallic clip capable of 330 rotation. And in China, we now have a platform of Shanghai Collaboration Innovation Center of the endoscopy. In the past 10 years, we aim to innovate research on minimum invasive diagnosis and treatment technology of the endoscopy. It took us 20 years to establish and promote the endoscopic minimum invasive diagnosis and treatment system. Turn contraindication of the traditional endoscopic therapy into the indication. So these are the new understanding of the concept of the endoscopic microdiscectomy. So I just mentioned as ERBEC, elements, reservation and resection, bilateral benefit, and expansion and collaboration. Thank you for your listening.